Welcome to our Spring 2019 Health, Racism, and Communication series. We're excited to present some information today about advancing health equity in New Orleans. We have two great speakers with us, but first introduce myself. I'm Megan Knapp. I'm Assistant Director of the Tulane Prevention Research Center. And today with us we have Danielle Broussard, and she's going to be speaking. She holds a PhD in epidemiology and is a graduate of Emory University and the University of Miami. She's a former assistant professor of chronic disease epidemiology at Xavier University and former director of research and evaluation at the Institute of Women and Ethnic Studies. Currently, Danielle is a research consultant and serves as a dissertation chair for several public health doctoral candidates. Her research includes studies of maternal and child health, women's health, chronic health conditions, and psychosocial aspects of health with an emphasis on racial disparities. Her most recent work has been focused on health equity and community health and well-being. And then we also have Maeve Wallace here today. She received her PhD in reproductive and perinatal epidemiology from Tulane in 2013. She completed a postdoctoral fellowship in the epidemiology branch of the National Institute of Child Health and Human Development with the National Institute of Health in Washington, D.C. Then she returned to New Orleans, where she is now research faculty in the Mary Amelia Women's Center at the Department of Global Community Health and Behavioral Sciences. Maeve's research focuses on contextual and policy determinants of maternal and child health equity, including structural racism, violence, and social policy. So join me in welcoming them here today. And I'm going to turn it over to Maeve. Thank you.
Thank you. Thanks, everyone. It's great to be here. Privileged to be part of this speaker series, a great series. I'm excited to be here with my co-presenter Danielle, and I wanted to acknowledge two other collaborators we had on this work, which was Catherine Theall and Lisa Richardson, who's at the Institute of Women and Ethnic Studies. But together we wanted to share our work that we've been doing on health equity and specifically within the New Orleans context. Let's see. So first, just some terminology to make sure we're all on the same page about the phrase health equity, which is really sort of a buzzword in population health these days. You might have heard a couple different definitions of health equity. I like this one, which says that health equity is a fair and just distribution of the resources and opportunities needed to achieve health and well-being. So it really gets at, not only just achieving health equity, meaning everyone has the optimal chance to achieve their highest level of health and well-being, but also how you do that is through the fair and just distribution of the resources that you need to achieve health. And so doing this requires removing obstacles to health, such as poverty, discrimination, racism, and their consequences, including powerlessness, lack of access to good jobs with fair pay, quality education, housing, safe environments, various other social and structural determinants of health, and health care for all people. So how do we look at New Orleans? You probably are all, live in New Orleans. This might not surprise you, but in terms of how the resources and opportunities for health are distributed within New Orleans, it's not very just at the moment. So here we can see the blue bars are non-Hispanic Black population, purple is white. So in terms of things like child poverty, we see among Black families, it's dark.
Is that better?
Yeah, is that too dark for y'all? Can you see your food?
Let's see what we can do here.
It does look better here, but whatever.
Can everybody see okay?
Good. We have an almost 50% child poverty rate among Blacks compared to only 9% among whites. Up to 71% of Black households earn less than a living wage compared to only a third of white households. And then we see not only racial but sex differences and stratify employment and educational attainment by sex and race. And so, as a social epidemiologist, I would argue as a result of that, we see these trends in population health inequities. So infant mortality 3 times higher among Blacks than whites. Low birth weight, preterm birth, those are serious adverse birth outcomes, about double the rates in Blacks compared to whites. Same for many chronic diseases, as well as mortality rates from some of the leading causes of death. So across the board, almost, we see higher Black mortality from things like HIV, diabetes, kidney disease, homicide, cancer, heart disease. So huge inequities persisting. So what is that about? What is race? Anyone want to venture a brief definition of the word race? Some brave soul out there? Yeah, Jackie.
I would start too, though. It's a social construct that was put in place to keep a segment of the population under control by white people.
Yeah, I think that's a good definition. Yeah, y'all often hear it's a social construct, which I think that alone maybe doesn't really get at how and why was it socially constructed, which is really important. So this is the definition that we wrote, which says that race is a classification of humans invented in the 18th century by European colonialists in colonial America as a means of establishing power over and justifying the treatment of indigenous people and enslaved Africans. Inequality was always central to the concept of race. It was never a neutral term, and it assumes the existence of natural or God-given differences between these groups. A hierarchy of exclusive racial categories was established by fabricating and arbitrarily ascribing superior cultural and behavioral traits to Europeans or whites, and inferior traits to non-European or non-white people. Over time, these false beliefs became deeply embedded in American society, institutions, and thought. But we're in the sciences, and we know that there's been a number of scientific advancements over the past century in genetics and biology, and we've confirmed that there are no genetically or biologically defined categories of human beings. Hopefully in this room we're all on the same page with that. But it's not that everyone is, and so maybe that sounds like an obvious point to you all, but these are just some recent publications that really are demonstrating that this issue about biologic race is a pervasive problem in our society. So this was from, let's see, it was published only 2 years ago, 2016, and this was a study that looked at beliefs about biological differences. And so here, study one, they have a series of statements, things that say things like blacks' nerves endings are less sensitive than whites. Whites have larger brains than blacks. Whites have a better sense of hearing compared with blacks. Black skin is thicker than whites. So study one was a sample of just white people in the population. And as you can see, the percentage of people that agreed with some of those false statements is large. Maybe not so surprising to you in the Trump era, but that's pretty disturbing. But then we look here in study two, which was of medical school students, first year, second year, third year in residence, and the fact that these are not non-zero. These are non-zero is especially disturbing. These are the people that are, responsible for knowing the physical and physiological ways to maintain health, and yet they're flying into this belief that there's some physical or genetic or biologic differences between people by race. And lest you think it's just medical students and medical schools that have this problem and that we in public health are much more woke than that. There was this study that came out, which was, I think this was 2015, also just 4 years ago, this century. And it was, it came out to a lot of fanfare. It's a report of major impact in AJOG, the American Journal of Obstetrics and Gynecology. This is a leading team of epidemiologists, perinatologists, and maternal fetal medicine doctors from around the country that led the fetal growth study, which was a huge study done by the NIH. And their aim was to establish standard growth curves for human fetuses, which we might use to define things like growth restriction, small for gestational age, various outcomes among newborns. So what they did here was they established race-specific standards for fetal growth. Does anyone have a problem with this? Or what might be the problem with this? And I should say they recruited, this was a nationwide study, huge study, recruited what they called low-risk women. So these are women with singleton pregnancies, no chronic underlying conditions, no pregnancy complications. What's the problem with this? Anybody? Nothing? So to me, this is codifying the racial inequity. This is saying that there's literally differences in the way that a human fetus might grow because of this, idea of race, because of the concept of race, which we've just shown is not a genetic classification of humans. Why would it have a differential impact on fetal growth? So of course we know things like exposure to racism and all of the contextual factors that place Black women at risk of having a lower birth weight baby are not because they are Black, but because they are Black in a racist society, in a context of, because they're Black in America, basically. But this ignores all of that. This is establishing that Black babies the standard of growth for Black babies is lower than other races. To me, that's extremely problematic. Even worse, this is like 18th century stuff. They're showing differences in head circumference, femur length, abdominal circumference. So hopefully you all will have a problem with that by the end of this lecture. So getting back to the New Orleans context, because that's where the body of this work was focused, I just want to talk a little bit about the history of the context in which the current inequities began and what we saw in today's inequities in New Orleans. So this is a really brief history with just a couple of little points of interest. Over the past 300 years, of course, there's probably an innumerable list of examples of scientific racism and racial discrimination in this city and in this country. And this is a little bit more in detail in the essay that we wrote, which I'll share the link to, but this is just a brief overview. So, of course, 300 years ago, New Orleans was founded and built basically by enslaved Africans who were imported to build levees, dig ditches, clear forests, and imported from the north even after the transatlantic slave trade was outlawed. And scientific racism began really right there from the beginning. And again, it was through the establishment of the concept of race and this belief in the racial superiority of whites, which was codified, and that connection between that superiority and physical health is what we call scientific racism. So it was thought that immorality, criminality, and racial characteristics inherent to people of color or Black enslaved Africans were the cause of many of the illnesses that they experienced. It was thought that they brought the disease upon themselves through their unsanitary living conditions, poor personal hygiene, this idea persisted despite advancements in microbiology and our understanding of how diseases are caused and spread. This was a quote from the Louisiana State Board of Health, now the Department of Health, back in 1919. That talks about, even though we lay aside humanitarian and economic interests associated with the Negro race, we still have to face the obvious biologic fact that this race of people is both potentially and actually more capable of disseminating disease among the white people than are the white people among themselves. Into the early 1900s, syphilis and gonorrhea were frequently leading causes of death in the city. And because of the sexually transmitted nature of the disease, it was used to strengthen this idea between race and immorality and health, because Black people suffered much higher rates of death from these diseases, not because of immorality, as we know, but because they were denied access to care and treatment. The Flint Goodrich Hospital was built in the 30s, and that was the only place where Black nurses could receive professional training, and the only private hospital where Black doctors and physicians could practice. So this is just getting at the continued inability to receive health care. And into the 60s, the Department of Health ordered the desegregation of state hospitals, but a year later, virtually none of the hospitals were compliant. And it wasn't really until the pressure from the federal government that said you will not receive Medicaid funding unless you desegregate, that the hospitals finally started to do so in the early 1970s. 70s, like this is, you know, not my lifetime, but it could have been within my lifetime. And then into the 80s and 90s, there was the building of black subdivisions, Gordon Plaza and Press Park, Morton Elementary School, and they were built on top of the agricultural street landfill, and residents were not told that's what was there. School students were not told that's what the school was on top of. It was an incredibly toxic site, later designated a Superfund site by the EPA, and exposed those people to untold amounts of chemical toxins. Then, of course, we had Katrina. The close of Charity Hospital changed the landscape of access to health care for poor and underserved people in this city. And then the uneven recovery of, as you all know, who was able to come back, who was able to rebuild, and the consistent stratification by race. So as I said, a lot of that is all more eloquently and detailed and put out in the essay that we wrote for the Data Center's Tricentennial Essay Collection. You can Google Data Center Tricentennial and you can read the full PDF. So I recommend you do that. And that report was actually the result of the project that we had started the year before through a contract that we got with the National Collaborative for Health Equity. So again, this was myself, Danielle, Kat, and Lisa. And we were the New Orleans team. So New Orleans was a specialty focus area for this national collaborative, which also had teams from these other places. So Prevention Institute, George Washington, were focused on looking at the national picture. We had people from University of Michigan looking at Michigan State, Mississippi looking at Mississippi State. University of New Mexico's team was looking at the indigenous tribes out in the West. We were looking at New Orleans, and the purpose of this whole project was to explore how does governmental public health play a role in advancing health equity, and with racial equity as a major priority, and how do we use community engagement as a central strategy to do so. So I think they were, you know, there's this trend going on where governmental public health, so that means health departments, are moving away from sort of direct service care and moving more into sort of upstream social determinants of health, population health inequities, and trying to address those as the role of public health sort of shifts in that direction. So in terms of what does the landscape of governmental public health and public health care in this city look like? Pre-Katrina, it was pretty much Charity Hospital that served most of the poor, although the health department spent a majority of its funding operating primary care clinics. So at that time, they were really more focused on that service delivery. But then, so of course, Hurricane Katrina happened, Charity Hospital closes, and then starting in 2010, the New Orleans Health Department began transitioning away from that direct clinical care services to moving, as I said, more upstream population health policy and program implementation. And then, you know, to fill in the gaps that were left by the clinic closing, by Charity Hospital closing, we have a series of community health centers serving people. And then we see huge cuts to funding. Of course, the enormously expensive UMC is built and supposedly taking over the job of charity and serving the uninsured. And then this is something we heard in some of our interviews with the health department people, which was a surprise even to us, that only 8% of its budget was currently covered by the city general fund. The rest they had to rely on grant funding for. So for this project, for the National Collaborative Project, we sought to go out and interview 18 key informants to get a sense of what was the governmental public health, so the New Orleans Health Department, doing in terms of advancing health equity and racial equity. So I'll detail on the next slide who we talked about, but we wanted to talk to not only leaders within the health department, but their partners as well, and anyone in New Orleans who might be working on something related to social determinants of health. So we interviewed them to talk about what would you say is health equity? How do you define health equity? How do you define racial equity? What do you think your role is as a health department in advancing health equity? What are you doing in terms of programming? What are you doing internally in terms of your own processes, assessments, and what are the barriers really to doing this work? And then talking about partnerships and how important that is to accomplishing this work. So methodology for this qualitative work, we had 2 team members at each interview. We coded the transcripts and identified common themes throughout. We also did a tertiary review of existing reports and publications and programs throughout New Orleans that we thought were addressing health equity. So this is just a quick or a full schematic of who we interviewed. So there were leaders not only at City Hall within the office of the mayor, but also leaders within sections of City Hall. So a lot of health department folks. Key informants there. We talked to the NOPD. We talked to code enforcement as sort of people that are relevant to certainly the social determinants of health in the city. And then partners and people that had worked with the health department. So that's the state health department. A couple of different people there. Someone at the data center, someone at the National Birth Equity Collaborative, and someone from Propeller. So just trying to get, the view from within and without the health department itself. So now I'm going to switch it over to Danielle to share our results.
So what we did in terms of organizing the data was looking at the barriers, needs, and opportunities that came out of the information that our key informants provided to us. Further, we broke those barriers, needs, and opportunities down into the different levels of the social ecological model. The social ecological model, or the SEM. I'll refer to it as the SEM. Is a theoretical framework that that allows you to look at aspects, and in this case in health, it's been widely used within public health, to look at the different aspects of the social environment that impact health. So we felt that that was a great way to kind of look at the different levels within this model, which includes policy, community, organizational organizations and institutions, as well as interpersonal and relational kind of exchanges, as well as the individual. So these different levels of the social ecological model allowed us to look at those different barriers, needs, and opportunities and kind of place them so that we could see, get a better picture on the back end about recommendations for how we could move forward. So first, at the systems and policy level, this is the highest level of that SEM model, or the SEM. Our informants were pretty clear on the role that the social determinants of health play in driving health inequities. That was without question. There was also this clear understanding that the systems that we have in place that serve members of the community were built on racism. We're talking about systems that were established at a time when oppression and racism were a part of the fabric of our society. They were ingrained in our laws. So there was this feeling that until we dismantle those aspects of our policies and systems, that we really could not move forward with addressing issues of equity, racial equity, or health equity. And in blue, you'll see some these are exact quotes from our key informants. So I've tried to identify some that reflect some of the key points that came from our interviews. In terms of needs, there were folks who felt like politicians and those in leadership may be speaking or giving lip service to some of these, the work that's being done to address equity, but it wasn't necessarily happening, or it wasn't moving along as they felt that it should be. Then at the community level, and I'll just make a note, there weren't barriers, needs, or opportunities that came out of each one of our interviews, or those that we felt were critical. Some of them fit within other areas, so you may see some where there's not an opportunity, or there's not a need, or even a barrier. But we've outlined the ones that we did identify here. So at the community level, one of the concerns that came, and this came from within the health department, it was recognized that many times there are assumptions that have been made about what the community's needs and wants are, rather than really taking part in meaningful engagement with the community to find out what those needs and wants are. And engaging with the folks who have the lived experience, who can tell us, this is what's going on with us, this is what we need, and this is how you can help. In terms of needs, we found that power sharing, many times we in public health, and it's not, I think it's just how we do things, just in general in society, we go into the community and say, this is what we can do for you, this is what you need, and kind of hand in hand with that barrier, instead of going in and saying, we want to find out what you need, and we're going to put you in a role of taking a leadership role in identifying what your needs are and figuring out what we can do to help you, but also allowing you to take a leadership role in helping yourself. And so that also follows this allowing the community to have a lead in taking on a leading role in ending racial inequities. So this opportunity that comes about from these interviews was that we should be partnering, public health and governmental public health in particular, should be partnering not just with the grass tops. What they meant by that was leaders within organizations, but also partnering with people on the ground, the real community members who are living these inequities every single day. So engaging in more partnerships there, and providing tools to community members so that they can be advocates for themselves, because sometimes people have ideas, they know what's going on, but they just don't have a voice. And this opportunity would give folks in the community a greater voice. At the organizational and institutional levels, there were several barriers and needs that were identified. The first was a lack of communication across government agencies. As you saw from the slide that Maeve showed, we talked to not just within the health department, we talked to code enforcement, we talked to folks at the NOPD, we also talked to people at the higher administrative levels, and felt that they felt that there wasn't a real good system for communicating what it meant to really address equity, to be on the same page about what equity means and what that strategy is for addressing equity. In public health, we often face this limited resources, meaning time, staff, and funding, to be able to do some of the things that need to happen in order to address equity issues. And then also the workforce not being prepared to address equity. We are finding more and more that schools of public health are starting to have more programming, more coursework around equity issues, and making sure that future public health leaders are more aware of what equity means and understanding the history and where we are currently and how to start thinking about addressing these issues. But that was an issue that was raised by some of our key informants, that the workforce was not there to be able to address equity. And also, I'm sure if you haven't learned already, you will be learning about the extensive responsibilities or the functions of public health. And many folks felt like adding this additional challenge of addressing equity issues and trying to pursue equity in the work that we do as public health practitioners found it to be a real challenge, just adding that on top of everything else that we're expected to do. Some of the needs were a greater internal understanding of equity. Again, this is the workforce that's not necessarily prepared to deal with equity, not having a clear understanding of what equity is. We had one informant talking about some of this could be addressed at the funder level, where funders are providing resources to different organizations and agencies to be able to address equity issues, but they're not sharing what other organizations and agencies are already doing. And that really ends up affecting the community, and sometimes the community misses out on services or resources that they may otherwise have access to because organization A doesn't know that organization B is providing that particular service. And finally, diversity in hiring within the health department. I felt like this was a really good quote where this informant says, if we want to serve this community, we should be reflective of this community. With hiring interns, I have someone on my staff say, I have the most qualified, and I say I understand, but I want the group to be diverse. Diversity is something you have to strive for and vigorously pursue. So what this person was meaning was that just because someone has a set of great credentials behind their name, it doesn't mean that they necessarily have a real perspective or a real connection to the community that needs to be served. They can come perhaps with great training and great grades from school, but that's not necessarily always the person who is great for interfacing with the community, who really has the community's best interest at heart. And she wanted to make sure that that in hiring within the health department, that both the credentials and that that experience, that not necessarily lived experience, which would be helpful, but having that kind of connection and ability to interface with the community, those things were both in place. So some of the opportunities. We found many of our key informants had already been through the Undoing Racism workshops, which I know that some of you here at Tulane have been through already. But these are offered by the People's Institute for Survival and Beyond, and provide an opportunity for individuals to sit down as a group and kind of unpack their own baggage, some of their own feelings and experiences, and to talk about how going forward we can address and end racism. These trainings were felt to be very valuable in this pursuit of equity within the health department and amongst the partners that we interviewed. But there were one of the things that came out of the interviews was that these types of trainings, maybe not the same training, but that frequent conversations were needed to keep that at the forefront, keep equity and racism, issues of racism at the forefront of what the workforce was doing on a regular basis, make it embedded in a part of the process that was happening within the health department. Also, equity in hiring practices as well as pay for health department staff. It was pointed out, and many of you may already know, that public health doesn't necessarily pay a whole lot, so there's a lot of turnover. There was a need for training that one of our informants talked about, the high turnover. There was a need for this continuous training on these issues around equity and racism, and having these equity trainings available to staff. And some of that might be solved by creating better equity in hiring practices and pay. Again, the intentionality and diversifying the workforce, which the informant talked about in that quote that I read just a bit ago. And finally, in terms of addressing that issue around this additional function that public health might take on in addressing or helping to advance equity, rather than necessarily having public health take on that role, have public health or public health officials serve as facilitators and bringing together the different systems that serve society, having them serve as a facilitator in ending inequities. So many different systems, and I'll talk about it a little bit later. That's where we see all of the impacts coming from. We see transportation and housing and healthcare, law enforcement, all of these things, and education impact one's ability to be able to achieve optimal health. So just focusing on it from a public health perspective is not necessarily the route that folks felt we should take. So we saw less coming from our key informants at the interpersonal and individual levels. But we did see barriers, a barrier being that people don't necessarily know each other. They don't understand another group. And that creates that makes it difficult to have some of these challenging conversations. When you sit people down together to talk about race, people from different groups, it makes it challenging. I mean, it's a controversial kind of issue, and I think public health has really done a good job of standing up to that challenge, maybe being a leader in doing that in society, and hopefully other sectors will pick up on it and carry it forward. Some of the opportunities there, one of the informants, this was another great quote that the same individual had, talked about a planning council that they have for the work that they do. And she makes sure that she has people there who have the credentials, who can speak to the medical needs of the population, but she also has people from the community who have the lived experience, and as she says here, they may not have more than a second grade education and a limited voice, but she and her staff are there to make sure that they do have a voice and that their experiences are on the table and not ignored. At the individual level, still talking about racism and how it influences each and every one of us to some degree, and we all come with our own personal experiences, biases, and perceptions, but being aware of those things is so important. And just being able to, you know, we're people, and, you know, that's just, we come with our own experiences, and that's okay, but just to make sure that we're aware of it. And that's what this first quote represents. So in terms of needs, we need a pipeline of future leaders who are committed to creating an equitable city. And the opportunities for doing this would be to support individuals who are currently doing the work. Those are individuals in the community, those are community organizations, those are student organizations that are currently doing the work, and making sure that their efforts are not going unheard and unsupported. So I have some recommendations here for governmental public health in particular in terms of moving forward in this quest to advance equity. The first is to understand the cultural and political context of health equity. And some of these recommendations have come from our national collaborative work. And this one in particular, I thought was interesting and important to point out, that we should be aware when you're working within a community. We here locally talked about racial inequity, and that resonated quite well with our community because of our history, the history here, legacy of slavery and oppression. So racial inequities made perfect sense. But we had some partners, some colleagues out in the Southwest working with tribal nations, and racial inequities didn't really resonate with them. There were other cultural or political meanings that had more, that were greater for them than was the racial aspect. So that's just kind of a take home, that if you're not working in a community like ours, really being aware of what the context is. Strengthening the internal capacity within the health department, and this included things like the diversity, and helping to make sure that everyone was on the same page and understanding what we're talking about when we say we are addressing equity, and what the strategy is for making that happen. Engaging more deeply with the community, again, really having that meaningful connection to the community, bringing them to the table, making sure they have a voice, and providing them with tools so that they can do some of the work themselves. Enhancing communications both internally and externally, making sure that there's a shared understanding of what equity is, again, and making sure that the community is aware of the services and resources that are available to them. Reassessing the role that public health plays. I talked about the many functions that public health is already expected to perform, and adding this additional layer of pursuing equity. That doesn't mean that we have to be the ones who lead the charge, but serving as a facilitator is one way that we can do it, and it can happen by building alliances with other sectors and bringing those many sectors to the table, because as I discussed, and Maeve did as well, health equity is not going to come from public health alone. It's going to come from these many different sectors working together. And finally, I've provided a link to the National Collaborative for Health Equities report. This is a full report. It includes findings from our local environmental scan, as well as those that were performed around the country. So I encourage you to take a look at this. It helps. It expands on the recommendations that I gave on the previous slide, but also gives you a greater perspective of what the experiences are across the country. And anyone who's interested in doing any kind of equity work, I think this is a great foundation for understanding it. So thank you.
Questions?
Question into the mic, so it reports it
Oh, gotcha.
whenever it's yes.
Oh, yeah, so repeat the question, yeah. Any questions?
Hi. That was a great presentation, thank you. I had some questions about the study you mentioned about the key informants that you interviewed when you just mentioned. I'm assuming there's a lot of diversity across those informants in terms of other characteristics that might influence their perspectives on what needs to be done. And I'm wondering if you identified any differences maybe from the health sector they represent, or the services they provide, or their own self-identified race, gender. You know, I'm assuming everyone's got a different lens and a different perspective. Did you identify any patterns?
I don't know. Did you want to talk
I mean, we
on that
didn't
one?
we didn't stratify interviews by race and look for separate, discrete differences that way. But I mean, in my own experience, you can definitely. We had a couple of white key informants that it's an uncomfortable topic to talk about, and you can sense their discomfort, which wasn't really as apparent with informant of color. Which I think in general we're just more at ease talking about racism and experience, possibly informed by their own, lived experience. And, I was surprised at some, NOPD and some of these places where I thought we were going to hear some crazy stuff. Across the board, everybody was, and these are leaders in these organizations, everybody acknowledged racism really as a fundamental cause of health inequity in New Orleans and the legacy of structural racism. So that was a nice finding. But yeah, did you notice other differences by race?
No, just what Maeve already mentioned, that there was some greater level of discomfort, especially and early on. We talked in the interview guide. It was early on that we talked more about race, and I think once folks got past that, there was a greater comfort level. But no, we didn't break it down. I mean, because we had such a small sample size to begin with. But that's certainly a great point, and something that we thought about as well.
And one thing that was interesting was that we started this project, got the contract, started developing the interview guide in October 2016. Remember the glory days. So November 2016 happened, and it really shook the whole national collaborative, and everybody, we had to have calls about what did this mean for the project, how should we maybe change what we're talking about, and so we really shifted more towards a broader picture of racial inequity, kind of overarching. Yes, health inequity is one aspect because we're public health people, but really getting at racial inequity and how does that, eventually impact health, but how do you address racial inequity no matter what sector you're working in? So that was interesting. Yeah.
Thank you so much for this presentation. To someone who is relatively new to New Orleans, I find this incredibly interesting and very informative. I have a question about the role of community in tackling inequities in New Orleans. And I think in one of the quotes you had, you said that one of your key informants said that community should take the lead in ending inequities. I'm always puzzled about this term community, especially so maybe you could tell us more about what you mean by community in New Orleans, and especially knowing that it's such a racially segregated city as well? And what entities in community could take the lead more specifically?
I'm going to repeat that question into the microphone. So what do we mean by communities taking the lead in ending equity? What do we mean by community?
What community entities, and what ways
Mm-hmm.
that work could be done?
So from the standpoint of governmental public health, and I guess I mean, certainly government is meant to serve all facets of the community, regardless of what your socioeconomic status is or what your racial and ethnic background is. But typically when we look at the public health system, especially historically here, it's been to serve the underserved, so your lower income population. And I think there's a tendency when we talk about community to focus more on the lower socioeconomic rungs within our community. And from this standpoint, many times the voiceless tend to also fall within that category. And I think what our key informants were speaking to when they talked about bringing community to the table and letting community take the lead, excuse me, it had more to do with allowing folks who have traditionally been voiceless to have that place at the table.
Yeah,
Did you
and
wanna
I think
add to
that's a really nice way of putting it. And I think if I'm going to be less politically correct, it means Black people in New Orleans who are the voiceless and the historically oppressed. So I think a lot of times we say, or public health says community, or New Orleans says, you know, we need community engagement when we need people of color at the table because the leadership here is white. That's maybe my own opinion, but.
And sometimes, there's a quote that I did not include here, where a health department key informant indicated that, you know, we'll have people of color at the table, but they tend to be the leaders within community organizations. These are not people who want for anything, okay? These are people who have means, who have money, and they're educated. So really speaking again to people who don't have a voice, and those tend to be people who have less economic means.
So what are the ways of engaging people who are like traditionally voiceless?
And that was somewhat of a challenge for the health department in thinking about how much time it takes to build a trusting relationship, because, and I'm not sure how much you know about at least our country's history, and then you saw what history that Maeve presented with respect to how the healthcare system and the public health system in this country has engaged with communities of color. There are real challenges there, and there are people who remember these things, and they don't trust the system. Most systems they don't trust, including the health and public health systems. So that was a particular challenge that one of the health department informants in particular that I'm thinking about expressed. So I don't know. Do you have an answer for that?
Yeah, I mean, they floated some ideas about like, okay, there's a long legacy of sort of exploiting the community by just asking for their input on a project, or what should we be, but actually making a way where they could be, come on board as staff in some kind of office of, community liaisons or something, paid to provide their input, paid to provide their connection to the community. I mean, they're not going to do that anytime soon, but that was something that, it was suggested. So I mean, thinking, yeah, it's hard, but I don't know of a way besides, community advisory boards and all these kinds of things that we do where we try to engage the community, but they're not reaping the benefits at the end of the day, and they're not being compensated for the equity work that they're doing. So, question? Yeah.
I have a comment and a question. If that's all right.
Sure.
I just really wanted to thank you both for this presentation, and I really am happy that you brought up the Gordon Plaza situation, because I feel like that's really, really not talked about. And even though it was like labeled as a Superfund site, which means basically like a site so toxic that no human should live there, even though Gordon Plaza was named as a Superfund site 25 years ago, there still has not been any like major or notable effort on behalf of the city of New Orleans to relocate these people. So that's just still an ongoing thing. And then my question is more about like engaging faculty in sort of like self-reflection on about like internalized racism and sort of just their framing and knowledge of health equity in general, because of how I feel like toxic professionalism norms like in academia are, with just people thinking like they always have to be working and just, I mean, that's the way that like they're incentivized here. It's just, you know, getting as many grants as they can, having all of these projects and whatever. So with like everybody's never ending to-do list and just like constantly just multiplying inbox of emails, etc. If it's not something that's already on a faculty's mind, what do you think are ways that faculty could be enticed to kind of like come up for air and do this kind of self-reflection, given that it's not incentivized?
Oh, I think incentivizing it is the only way to do that. So making it, you know, making that kind of work count for things like tenure and advancement, making that kind of work important to demonstrate before someone comes on board as a new faculty member. Just diversifying the faculty is the first step. So, you know, the title of this talk is Communication Within and Without is to emphasize that institutions have to start looking within first before you're going to go out and start engaging and doing meaningful health equity work with a community. So Tulane, looking internally, what are our hiring practices? Who do we have right now? Why are we all white? And then, you know, what is the work that we value in terms of products for people that can advance? And I think so. It's definitely institutional level change and somehow incentivizing that work. I mean, it's tough because grant funders don't really, you know, privilege that work. So if you've got to get funding to keep your job, you know, it's tough. So it's going to take a lot of change across many institutional landscapes. But stuff like this seminar, and hopefully, I don't know if there's a single faculty person in here, but you know, yay! Awesome. Yay. So yeah.
The only thing I wanted to add to that too is that there's racism in funding too. So to sustain faculty who are people of color is also going to be a challenge. So even at the highest rank at the NIH, there still is in terms of funding. So sustaining faculty with people of color is a challenge.
Yeah, I wanted to echo the thanks for this presentation. I think it's, I think it's important to take stock before you can like really decide where to go next. But in the spirit of like looking towards what's next, I was wondering if you guys looked at other cities and communities who have like started to do some of this like deeper work, whose work you really admire. Because I mean, we're hardly the first people to do this, and we're going to have unique challenges. Because New Orleans is unique, as we all know. But I always like to look for best practices so that we're not spinning our wheels trying to invent something that somebody's already done really well. So it's a long-winded way of asking if you think other people are doing this well and who they are.
Yeah. So look at the full report for those other sites. Michigan, they're doing a lot up there. They've got the Flint issue, of course, and Detroit. New York City, because they have billions of dollars, are doing some really great things, especially in terms of reproductive health equity, which is what I'm interested in. So they're starting to address issues of maternal mortality as resulting from racism, as structural determinants, at a health department that's pretty innovative. Are there ideas?
Yeah, and I could absolutely, if you give me an email address, I can point you in the right direction, because there are best practices that are out there, and I found a compilation of them that I have bookmarked on my computer. But I would be happy to share that with you, because there's certainly cities, many of them I found to be out on the West Coast.
Yeah, California is always pretty good on that stuff too.
Yeah.
But there's a lot of non-governmental work being done. So there's the human impact partners have like very direct guidelines and recommendations for health equity. There's this like Public Health Awakened, which is another group that is trying to move governmental and non-governmental health, public health work towards an equity lens. So there's a lot out there. I don't know, I can't point to a health department I'm sure there's one that's having success, but
Yes, and that's what I provide to you. There's several. Okay. Again, on the West Coast, all of them down on the West Coast. Okay.
Great.
Thank you so much for joining us today. Thank you for speaking. This was great, and learned a lot and expanded our minds a bit. So thank you. I appreciate it. Our next seminar